Good evening all to the 75th session of the Weekly Huddle. I'm your host Anoop, and joining me today is my colleague and co-host Dr. Praneeth. We both are cardiologists at Banjara. Most of you are regular attendees of the Weekly Huddle, so I'm going to skip the introduction part. Today's topic is more what I should say internal medicine than cardiology, but at the same time this is a topic that each one of us faces, and sometimes more frequently than what we would like to. And in my limited experience seeing patients, I have noticed many of the times it gets missed in our discussion. So I thought we'll discuss about this very basic, very simple, something that we all know how to manage, but still worth discussing, and that is iron deficiency anemia. I believe this is one of the first pathology lectures that we get, a clinical pathology lecture that we get in our MBBS days. I am joined by some of my internal medicine colleagues to help us in managing this discussion for today. So I'll read out the case, and then I will ask Praneeth for his opinion, and then we will take opinion from our attendees as well. So Praneeth, this is the patient I saw very recently. He's a 42-year-old male, and as I'm talking about this, I remember as I was telling you about this case, literally in front of me, one of your patient came with a similar complaint, although the age was slightly different. So this is a 42-year-old male who is being evaluated for non-specific weakness. He runs a small business of his own, and lately he had been noticing just vague fatigue, early fatigability, weakness, and whatnot. Somebody suggested him, why not get a so-called complete heart checkup, complete body checkup. So he got a package, which is a master health check. And then as a part of the package, he was supposed to see a cardiologist, and that's how he landed up in my OPD. So I won't tell you all the details of his reports, most of which were okay, including echo, ECG, TMT, which was part of the package that he got done. But the relevant findings for today's discussion is that his fasting sugar was 135. Hemoglobin was noted to be 9.2 with an MCV of 66. The rest of the parameters in terms of other blood tests and whatnot were normal, so I'm not commenting on that. You can get a sense of whatever we do in our routine master health checkup. So because of his increased fasting sugar and low hemoglobin, which looked hypochromic microcytic, I did order a quick follow-up lab, which included an HbA1c and a serum ferritin. His HbA1c came out to be 8.1, labeling him as diabetic, and a ferritin of 12, which kind of confirmed the diagnosis of iron deficiency anemia. So I made a new diagnosis of diabetes as well as iron deficiency anemia. We discussed about diabetes management and all this, which is not the point of today's discussion, so we are going to skip that. Today's discussion is about iron deficiency anemia in males, and by extension, you can also put it up for postmenopausal women as well. For today's discussion, let's just stick in males. So the questions that we are trying to address here in patients like these with a hemoglobin of 9.2, with symptoms kind of difficult to ascertain whether they were anemia related or diabetes related or a multifactorial, I don't know. And I still didn't have enough time to see whether his symptoms responded to the diabetes treatment. So the question that we are going to discuss is how to replete iron stores in these cases. Is oral therapy sufficient, or should we go for intravenous iron, or is there any other tool that you use for these patients? Second question is, when to evaluate for iron deficiency anemia cause in terms of what are the red flags? Is being male an enough red flag for us to start to initiate discussion? Because I'm guessing a 42-year-old female, otherwise most of us would just do iron therapy, although whether that is right or wrong, that also we can initiate a discussion. Then the question is, if you do want to evaluate for iron deficiency anemia, what are the first order of investigations? I'm sure that if we go by the algorithm, there are a ton of things that we can do. The point of discussion is what should be the first order of investigations or referrals that we should be doing in these set of patients. And then last but not the least, deworming therapy, as we all have been taught that intestinal worms in India become one of the common reasons for iron deficiency anemia. So should we be deworming all of these patients, or should we first do some diagnostics and then deworm? We all have been taught that we should first treat anemia before we do the deworming therapy. So how long do we wait or whatnot? So a lot of discussions, very basic, and I am trying not to delve into too much into the intricacies of it, but a first line management of these kind of patients. So Praneeth, over to you, and then we will take opinion from other attendees of today's session.
Yeah, good evening, Anoop and everyone. Definitely a common scenario, and as you mentioned about one of the patient which you said we were discussing, I could encounter few more patients in the last week of our discussion after you mentioned about iron deficiency anemia, and definitely now the way you look at them makes it is different. Now, before I start, because I find some residents also in the group, and being a cardiologist, the evaluation of coronary artery disease in the presence of anemia is should be kept into consideration, because anemia is the greatest mimicker of any cardiovascular symptom or disease that we talk about, and anemia blows up everything. And there are a lot of instances where you are completely bowled, where anemia could explain all the symptoms. So just for the sake of it, when there is anemia, there is no CAD, heart failure, anything. Anemia takes precedence, and only then correct anemia, and only then we look into when we come to heart and other things. Now, coming to the discussion part of it, iron deficiency anemia, you already made the diagnosis of iron deficiency anemia. Or else, if we begin with anemia per se, as a microcytic anemia, you look at the other causes like any thalassemias or other issues. But here, you already did diagnose ferritin being low, one of the sensitive markers for iron deficiency anemia. So the diagnosis is already made. Most likely cause, we lose iron, external blood losses. Internal blood loss, you don't expect iron deficiency. So the cause is external blood loss or any other deficiencies of iron metabolism. Most likely it is a external blood loss. Now, when we talk about an external blood loss, obviously, if there is an obvious bleed in the form of a bleeding piles or large amount of frequent epistaxis, patient would be able to know. Most of the time, it is too small for the patient to notice the so-called occult blood loss that we talk about, and commonly it is the GI blood loss. Most commonly, again, upper GI in the form of a peptic ulcer, which is quite frequent, H. pylori or whatever. So I believe the evaluation should begin with trying to find out whether patient has any occult blood loss happening, and the workups would be to start with a stool for occult blood, and probably if it is positive, you have a definitive confirmation, and you definitely are subject for endoscopy. And I believe we have to take at least 3 samples for stool for occult blood to be really sure, and saying that the stool for occult blood is negative. If it is positive, it makes it more you are happy that you have a diagnosis, and you continue to search from top to bottom where is the patient bleeding. If patients, most of them should be subjected to upper GI endoscopy, where patient we may be able to find the reason for the bleeding, and sometimes patients may have a normal endoscopy, which is where it becomes challenging. The bleeding could be something like a dualifoid lesion where it bleeds and it stops, and you may not find it, or sometimes it is in a smaller intestines, which again is challenging, where you need to keep poking to find the reason for GI losses. The postmenopausal woman or an elderly male or should definitely be evaluated, and we should not leave them. So definitely try to find as much as you can to find the source of bleeding. The point that you mentioned about deworming is excellent because that doesn't come into mind in general. Deworming is something which is limited, or the thought process for me at least is limited to only children because of their habit of pica or contaminations or whatnot. But when we deal with adults, the deworming thing, at least for me, doesn't strike up. But probably yes, there is no harm in giving one shot of albendazole, and if there are worms, that they can it can be taken care of. But that is definitely one thing which is the nice topic that you brought in for discussion. So these are my thoughts, Anoop. If there's anything I can add.
So Praneeth, you mentioned a lot of generic points. I'm trying to get a sense of this particular patient. So let's say this patient comes to your OPD. You have already diagnosed him with iron deficiency anemia. Tell me, what am I going to see in your prescription pad? And if you need any history, you ask me the history.
Not much. I would ask whether he has any bleeding, which I believe is not there.
Right.
So I would ask him for an stool for occult blood, and I would ask for I would give him iron therapy. I would give him oral iron tablets, ask for stool for occult blood, and report to me after with the stool for occult blood report.
Okay. All right. So that, I'm guessing that will be your initial evaluation for this patient, right?
Yes.
Right. And we are not talking about all the weird things. We're not talking about multiple myeloma and whatnot and all those. So I think I'm getting the impression that you will start with a GI tract and then make your way up, right? That's
right.
That's what my
right. Right.
You don't refer the patient to gastroenterologist directly, right?
I would first try to look at the stool for occult blood, and I have a valid reason to send. But if the index of suspicion is high, I would do. But I would start with stool for occult blood and then take it forward. But my threshold to refer to gastroenterologist is low.
Okay, all right. I'm directly going to jump into the expertise here. Dr. Shankar is here with us. He's a general physician. Dr. Shankar, this is your forte. I hear you sometimes starting your discussion saying that this is a cardiologist topic, but you will try. This is exactly your topic. My question to you is, what is the role of stool for occult blood in this case, and how would you approach this case? Dr. Shankar, all yours.
Good evening to all. Congratulations to Dr. Anoop Agrawal and Praneeth Palamuri for a successful 75th session of Weekly Huddle. This is definitely a case of iron deficiency anemia. He has got hemoglobin of 9.5 and 9.2 and MCV is 66. So MCV below 80, it is microcytic and hypochromic anemia. So here, when we come across hypochromic microcytic anemia, we should think of 5 conditions where we get this hypochromic microcytic anemia. One is iron deficiency anemia. Second is beta thalassemia or alpha thalassemia or thalassemia trait, hemoglobinopathies, that is fetal hemoglobin. Then anemia of chronic disease, urinary tract infection, chronic kidney disease, tuberculosis, sarcoidosis, collagen vascular diseases, rheumatoid arthritis, scleroderma, inflammatory bowel disease, and including diabetes also. This patient has got fasting blood sugar 135, postprandial and HbA1c also to be done, and to confirm that he has got definite diabetes, because fasting blood sugar is more than 125. So diabetes also comes under anemia of chronic anemia of chronic disease. Then the fourth one is lead toxicity, and fifth one is hereditary or acquired sideroblastic anemia. So the serum ferritin here, the serum iron or the serum ferritin here it is low, it goes in favor of iron deficiency anemia. So iron deficiency anemia is confirmed. But what I mentioned, the 5 conditions, definitely they masquerade, and as well as if they come in the differential diagnosis. So having diagnosed, it's a case of iron deficiency anemia, then the main causes of iron deficiency anemia is poor intake, dietary intake, poor iron dietary intake. So, and if the patient is vegetarian, though he consumes non-heme iron, so the hemoglobin may not be synthesized properly, in the erythropoiesis may not be that enough. The heme iron, which is there in the non-vegetarian diet, that increases the hemoglobin levels. And if the patient takes along with the phytic acid phytates, or if the patient takes along with the proton pump inhibitors, or patient takes along with the antacids, and if the patient takes PPIs or H2 blockers, then he develops achlorhydria. The hydrochloric acid in the stomach will be less. So this all will cause the hamper in the absorption of the iron. So the decreased intake of the bioavailable iron and poor absorption of iron. Then increased blood losses we have to search for. After going through this dietary history, absorption and all, then blood losses, whether he has got hemorrhoids or hematuria, or whether patient has got a peptic ulcer, we have to search for. Then upper GI endoscopy has to be done, or even colonoscopy also has to be done. So before that, as Dr. Polamuri Pranith told, occult blood test, benzidine test has to be done, so that the occult blood, if it is there, then we have to go for this endoscopy procedures. And this occult blood is also seen in celiac disease. The celiac disease, which is a screw, we thought that it is a northern disease, but now we have seen many cases of celiac disease even in Andhra Pradesh and nearby South India states also. So where we go for IgA level, because I have got one case of celiac disease recently. Patient was refractory to an iron deficiency, refractory iron deficiency. So we did IgA level of the tissue transglutaminase. Then that came positive. So gluten enteropathy we diagnosed, and the gluten-free diets we advise. Then hepcidin. This is one has to think of. This is an acute phase reactant, a protein it produced in the liver. It is increased in the inflammatory conditions. This will retard the absorption of the iron. So we should look for the hepcidin levels also. If the hepcidin levels are more, then any chronic inflammatory condition, whether the patient is having or not, we should search for. Because the hepcidin, this hampers the absorption of the iron. Then having seen this celiac disease, inflammatory bowel disease that the patient is having, and gastric malignancy, so these will be ruled out by the endoscopy procedures. And one more condition, though it is rare, but we have to think of when the patient comes with the B12 deficiency. This patient is a diabetic, so metformin, one of the causes for the B12 deficiency, and the autoimmune gastritis, autoimmune atrophic gastritis, where we go for anti-intrinsic factor, gastrin levels, and the parietal cell antibodies and all will diagnose. So very important in our India, especially in the rural areas, these worm infestations, the hookworm, the ankylostoma duodenale, that is quite common, where so we have to look for this hookworm infestation. And that's why we want to give deworming. So empirically, we give deworming so that whipworms, pinworms, threadworms, roundworms, the hookworms, all will be washed out with one single dose of albendazole. The 400 milligrams of albendazole, if it is given, and it can be repeated after 2 weeks. And one more important thing in our country is giardiasis. The giardiasis is a chronic diarrheal disease with malabsorption. So it's quite common, this giardiasis. So metronidazole can be given to the giardiasis, can be stool examination can be done, and if you suspect the giardiasis, we can give metronidazole. So these are the conditions: the infections, infestations, increased blood losses, poor absorption of the iron, and decreased intake of the bioavailable iron. So having examined all these things, then if it is, we may come to know what could be the cause for this anemia. Then after deworming, along with the deworming, we give, I give here oral iron preparations, especially the ferrous sulfate. This is ferrous sulfate is so many are there: ferrous fumarate, gluconate, ascorbate. Ferrous ascorbate is also a good one amongst the oral preparations. So I give 325 milligrams daily or alternate days. Here I want to tell, see, since the hemoglobin is, for example, a patient has got 6 grams. So everybody prefers to give twice daily or multiple doses. See, multiple doses should not be given. Even daily or alternate days is sufficient enough. Because if you give iron orally, that will stimulate the hepcidin and hormone which is released from the liver, that retards the absorption of the iron. So if you give multiple doses, the more amount of hepcidin will be released, and that will retard the absorption of the iron. And more side effects will be there with the iron preparations, like nausea, constipation, some dyspepsia, vomitings also to some extent. So I give preferably daily or alternate day in this case. And one thing, and I will stop here this thing. Then whether patient responded to oral iron or not, because we have given very good iron preparation, because the sophisticated iron preparations are there in the market which are entry coated and may not be absorbed properly. So iron sulfate, fesovite or fefol, they contain iron sulfate. That is an ideal one. Or ferric ascorbate, that is orofer, that can be given. Ferronia, orofer or some. So these 2 iron preparations can be given. So if the patient, after immediately the reticulocyte count, actually in iron deficiency anemia, reticulocyte count will be low, less than 2%. From 3rd day or 4th day onwards, the reticulocyte count starts rising. So that is a good indication that the patient is responding to iron deficiency anemia. And the second thing is, after 4 weeks in the mild anemia, here is the mild case, it is a case of mild anemia, because here hemoglobin is 9.2. So it is a mild anemia. So I give iron preparations, and then look for hemoglobin percentage after 4 weeks. Then there should be rise in, it should be, instead of 9.2, it should be 10.2. More than 1 gram per deciliter should rise in 4 weeks. In moderate to severe iron deficiency anemia, the hemoglobin is less than 9 grams. The hemoglobin rises within 2 weeks, it rises by more than 1 gram. So with this, whether the patient has responded to iron therapy or not, whether he has tolerated or not, we come to know. With this, I stop and I join with others and I further discuss regarding the iron deficiency. And this is my favorite topic. Okay, thank you, one and all.
Shankar sir, I'm going to ask you the same question that I asked Praneeth as well. This patient comes to your OPD. What will I see in your prescription pad? What all orders you will write in the first visit itself?
First visit, we do serum of this iron profile.
Ferritin we have already done, sir. Ferritin is normal. Do you want to do? Do you want to still do iron profile?
No. Because I'm telling when we patient gets the only CBP report that 9.2 grams hemoglobin and the MCV is 66. Then one more thing in the hemogram, so many things are there. We can the electronic cell counter gives a lot of information. The RDW, we don't care, but RDW it gives a lot of information. And second is the Menger's index or Sagal index. This is quite useful at the bedside. That is mean corpuscular volume, MCV by RBC count. If it is more than 13, it goes in favor of iron deficiency anemia. If it is less than 13, it is a beta thalassemia. So with the CBP, if it is a beta thalassemia, so for example, the Menger's index is less than 13, we go for hemoglobin electrophoresis. Then fetal hemoglobin will see whether it is a trait or alpha or beta thalassemia, and that one different. Then we go for iron profile. Reticulocyte count. These are the things initially. And what I discussed about the causes of iron deficiency anemia, we have to investigate what I enumerated in the previous talk. And then I give prescription of ferrous sulfate, that is a Fesovit. Then a deworming, albendazole, 400 milligrams, and a repeat after 2 weeks. This is my prescription.
Perfect. Thank you so much, sir. We have Dr. Guru Prasad here with us. Dr. Guru Prasad is internist practicing at Care Banjara. He has joined us previously as well. Guru sir, welcome to the huddle. Welcome back to the huddle. And please tell us what kind of prescription I will see in your prescription pad for this patient, the information of which I have already given. Ferritin of 12, hemoglobin low, MCV low, 42-year-old male, no other complaints, no other obvious complaints. Guru sir.
Yeah, thank you, Anoop, and it's nice to be back in the huddle. So coming back to the history, you told that this fellow is a shopkeeper and he owns a small shop and he runs a small business, right? And that's what you had told me. So I would actually ask him about his intake of tea on a daily basis, how much tea is he drinking, or whether he is having tea after his meals. Because tea contains a lot of tannic acid and it really retards the absorption of iron from the food. It's one of the main causes of malabsorption, because the tannic acid retards iron absorption, number one. Number two, as someone was mentioning about PPIs and antacids, they have been described as one of the causes of iron deficiency anemia, but they have not really been corroborated that they really cause significant iron deficiency anemia. Third part, I think in this patient, you're asking for my prescription. Couple of things missing in the history. One is that the history of weight loss is there or not. Second, any recent onset dyspepsia is there or not. Number three, any history of malignancy in the family in the form of a colonic carcinoma is there or not. Anybody underwent a colonoscopy or polypectomy in the family is there or not. Also forms my basis of writing a prescription for this patient. According to AGA guidelines, any person of the age of 50, any male or female or postmenopausal female above the age of 50 should undergo an upper GI endoscopy and colonoscopy as a routine workup for iron deficiency anemia. But having said that, this gentleman is 42 years old. So there is some controversy regarding this age group. Bailey Love says that any male above the age of 40 comes with new onset dyspepsia, you should ask for upper GI endoscopy. I think for this patient, my prescription will first be ask for a retic count, ask for a stool for occult blood before starting iron therapy, because iron therapy per se can cause a false positive stool for occult blood. And number 3, ask for an upper GI endoscopy. And if the upper GI endoscopy is normal and there is no evidence of H. pylori infection by a rapid urease test, please mind it that you have to ask for rapid urease test from the gastroenterologist. They don't routinely do it on an upper GI endoscopy. Ask for rapid urease test when you're asking for an upper GI endoscopy. Stool for occult blood is negative, and suppose the retic count shows that it is a hyperproliferative anemia, I would start the patient on iron preparation, preferably on a ferrous ascorbate, because vitamin C, the ascorbate actually increases the absorption of iron from the gut. Also, iron should be taken empty stomach because that increases the absorption of iron, but it is precluded by GI intolerance. A lot of people cannot tolerate iron on an empty stomach. But that is the correct way to give, and that is what is mentioned in all hematological textbooks. Measure the retic count after 2 weeks to see if the reticulocytosis is there or not. If it is not there, then look at cause of malabsorption. Coming to the topic of deworming, that is one of my favorite topics. I generally tend to deworm a patient with ivermectin and albendazole, because albendazole is not the drug of choice for strongylosis cercosis infection. We generally give ivermectin. So the combination tablets are available commercially in the market. So I would use a deworming, a ferrous ascorbate combination, retic count, stool for occult blood, upper GI endoscopy.
Okay, sir, I'll answer some of the questions. You said dyspeptic symptom is present, although that was not his primary complaint. It was on leading questions. He does not have any obvious weight loss, and there is no family history of early cancer. So those were the questions you mentioned. He is non-vegetarian and he has got a routine diet. He drinks tea a couple of times a day, but nothing too crazy. In fact, I drink more tea than him. A few questions about what you mentioned, things that you mentioned. My first question is, and this is a little bit controversial question, but I'm going to ask, sir, what is the role of stool for occult blood? Are you not going to do an endoscopy if his stool for occult blood is negative?
So the stool for occult blood has got its own set of, its sensitivity is quite low. First of all, even if you take 3 samples, the sensitivity comes up to around 70% or so, not more than that, in fact. So if I'm evaluating a patient for a lower GI cause, its sensitivity increases actually. Stool for occult blood, you have to understand that its sensitivity is increased lower down the GI tract. So if it is probably from the distal small bowel or the large bowel, the sensitivity of the stool for occult blood increases. So in this patient, I would actually go with an endoscopy. That's why I said earlier also, endoscopy will be a part of my routine investigation. Depending on the stool for occult blood, probably I'll decide whether he requires a colonoscopy or not.
So I vaguely remember during my training, this was hammered into our thought, and whether it has got any scientific basis or not, I didn't test it at the time. What was hammered in our thought was stool for occult blood is a test for cancer screening, not for anemia workup. The test for anemia workup for GI is GI endoscopy, be it up or down. But the stool for occult blood was put on because in the Western world, in Caucasians, colon cancer is so common that stool for occult blood was used as a screening tool to screen for colon cancer. So that was something which was hammered in my thought, that for anemia you do endoscopy, don't do a stool for occult blood. It doesn't.
So I'll put it the other way around. See, most of the cause of anemia, if you look at the cause of anemia, they are more of malabsorption which causes anemia. The general causes, as it was enumerated before, that in our country the commonest is still hookworm infestation. That is the commonest cause. I mean, that goes without saying. Other causes are always secondary. Celiac sprue and other causes of malabsorption are always secondary. So upper GI endoscopy covers most of them. If you take a duodenal biopsy, you can find out whether the patient has got celiac sprue or whether the patient has got giardia infection or not. Most of them are covered if you do an upper GI endoscopy. But also we are seeing in younger age groups now, polyps or CA colon as the cause of iron deficiency anemia. Especially right-sided lesions in the colon are one of the how they present as iron deficiency anemia. So we need to understand that a combination of these two, especially with the increasing prevalence of cancer in our society, I think the moment we miss early stage cancer, you are subjecting a patient to unnecessary chemotherapy, radiation, and a lot of a huge burden in terms of finances and medical care. So I think screening should be a tool when we know that it's uncommon to find anemia in a male who is economically not deprived, who is running probably a business where he can afford to have a normal food. I think we should not go back in terms of investigating a patient for cause of anemia.
My second question is, do you routinely check B12 deficiency even when it is quite obvious that there is iron deficiency anemia going on?
So when it's like with such a low MCV, like 66 in a patient, I would actually stay away from checking for B12. But a lot of people do disagree because they when there's a combination of iron deficiency and B12 deficiency, we should understand that the B12 deficiency actually predominates there. In terms of causing changes in the peripheral smear. Generally, either they have a normocytic anemia or will show some macrocytosis or some hypersegmented neutrophils. So any good pathologist can give you that answer if there's any suspicion of B12 deficiency in the peripheral smear. I think the peripheral smear is often less used by clinicians to look at or as a tool to diagnose a case, because the peripheral smear gives a lot of information, a retic count, a simple retic count. So in a patient who is having B12 deficiency, retic count will actually be near normal or a little on the higher side because there is some hemolysis going on. The B12 deficiency actually takes over the iron, probably it masked iron deficiency, because somehow it is the bigger brother and it causes more changes in the peripheral smear as compared to iron deficiency when both of them coexist.
I'm going to ask a few more questions to you, sir, and then I'll get back to you, Dr. Shankar. You mentioned peripheral smear. Is it like, while in theory peripheral smear is pretty good, do you think labs do a pretty good job with peripheral smear?
Well, I can say very proudly that in Care Banjara we do have a very good person who does the peripheral smear pretty well, and we do rely on it. And more often than not, we have actually succeeded in making some diagnosis made on the peripheral smear. But yes, I agree with you that a lot of times, labs give the machine counter readings, and that may not be the correct thing to interpret. So that there you need to use a clinical listing. As Dr. Shankar was mentioning about RDW, a high RDW actually says that there is thalassemia rather than iron deficiency anemia. RBC count is in the lower side. Probably it again points more towards iron deficiency anemia. So on and so forth. There are a lot of things which you can interpret by machine report also. So I think that peripheral smear is underrated. I would say that it's not overrated; it's underrated in our in our setting. Probably we should make more use of it rather than asking for a more expensive test. I think doesn't make any sense.
Is liver function test part of your first assessment in terms of albumin globulin ratio or whatnot?
You want in this patient, or are you asking generally?
This particular patient, 42-year-old.
So in this patient, a liver function test will be important because an alk phos elevation will give one clue towards Celex Prue, because in Celex Prue patients, more often than not, we find a elevation of the alkaline phosphatase, which is from the intestinal origin, and that may give a clue to an underlying celiac disease.
How about albumin globulin? Do you think that gamma globulinemia or all these are?
No. I'll put it the other way around now. An increased alk phos and the low albumin will tell me about malabsorption, because albumin has got a short half-life. So if albumin is low, then probably I know that this patient is having some kind of a malabsorption, and because of which the albumin is low. If there is a chronic worm infestation, the globulins might go up. If there is, suppose, a chronic liver disease, then a varices are there, and which would have caused some incipient bleed and all those, so on and so forth. All those things will come up. But in this patient, I think two things will give me information in LFT. One is an increased alk phos, which might give some clue regarding presence of Celex Prue, and second is low albumin, which might give me some kind of clue about his nutrition state.
You mentioned about deworming. We remember from MBBS that we always replete iron before we do deworming. Is there a scientific basis to that now, or now we pretty much give both at the same time?
We're giving it at both the same time. I'm not really sure about the scientific basis of of deworming the patient after correcting iron deficiency. I am not really sure about that because it's not mentioned in any kind of textbook anywhere. If there's any reason behind it, I'm sure anybody can enlighten me about it.
The idea here is that the deworming may cause, may hasten the bleeding, the GI bleed, and may worsen the anemia. That was the whole idea behind it. Whatever it is.
I don't think so, because generally what the bleeding which occurs in because of worms, the way hookworms cause, that is the commonest cause of anemia in our country anyway, is that they cause microscopic bleeds, and the only thing which you have to warn the patient that they might have some loose stools in the subsequent day after taking the deworming tablet.
Guru sir, there are two questions which are asked in the chat box. I'll ask you and then we will move forward. Number one is, how effective are iron preparations which are marketed as no GI side effect, like iron pyrophosphate? I've never used it. What is your thought? Good, bad, doesn't work?
I have never used, and I generally use something like a ferrous ascorbate combination, or the conventional ones are ferrous sulfate, which Dr. Shankar, because they are very cost effective and they are used as a part of the routine iron preparation given in pregnancy. So, but scientific basis is for combining iron with vitamin C, because the vitamin C increases absorption of iron. I don't think there's any drug, any iron, because they all are eventually elemental iron, so they are bound to cause some GI discomfort, dyspepsia or constipation, it's like very common to encounter these side effects. And one more thing which you are told about intravenous iron was that intravenous iron is to be used only in patients who have either some kind of intolerable GI side effects or malabsorptive conditions. In them only we should go for intravenous preparations of iron.
Then the last question I'm going to ask you is what Praneeth asks: should we ask for duodenal biopsy routinely whenever we order upper GI endoscopy in these kind of cases?
Actually, it does make sense to ask for a duodenal biopsy and a rapid urease test for H. pylori, because once you've done an endoscopy, it's an invasive procedure. It is not comfortable for the patient to undergo it again and again. Second is that IgA, anti-TTG antibodies, endomycin antibodies are expensive to ask as tests, and it is, though they are very specific, it's precluded by its sensitivity, which may not be as sensitive as a upper GI endoscopy or duodenal biopsy. It can, your upper GI endoscopy and duodenal biopsy can also diagnose atrophic gastritis, because they generally when you do an endoscopy, they can have a look at a macroscopic view on the endoscope, and they can also see whether there's any changes are there in the duodenum, which generally occurs in colex too. But yes, I think a biopsy would give us much more information.
Thank you so much, Guru sir. I'll let you pause for a few minutes while we continue our discussion. Dr. Shankar, you have something to add or question?
Regarding this structurally, in the endoscopy, structurally any lesion may not be seen, even in the hookworm infestation or H. pylori infection or giardiasis. Or one more thing, even the chronic usage of NSAIDs, especially the aspirin and diclofenac sodium and other analgesics, if they are given, patient may not show any structural lesion in the stomach, but there will be occult blood. That's why occult blood should be done, because in hookworm, H. pylori, giardiasis, and NSAID or aspirin usage, there may not be any structural lesion. And second thing is the Meckel's rarely, but the Meckel's diverticulum in adults also. So that also causes some anemia, which is sometimes maybe refractory. And the second thing is regarding recently, not recently, but more than 2 years ago, the FDA approved this ferric pyrophosphate citrate. That is triferric. It is marketed in the US. Is ferric pyrophosphate citrate. It is in addition to it is an additive to the dialysate. It is designed to replace 5 to 7 milligrams of iron that the patients with this, chronic kidney disease, they tend to lose during each hemodialysis. They lose, so that will be corrected by this ferric pyrophosphate citrate. So it delivers a sufficient iron to the marrow, and but it doesn't increase the iron stores. So that is the beauty of this pyrophosphate. This is orally also available now in India. That is a Socril from Sun Pharma. That is pyrophosphate. So that I am writing, especially in chronic kidney disease patients, CKD patients, I am writing. This will, most of the times, it will obviate the need of parenteral iron therapy, especially in CKD patients. Thank you.
Thank you so much, sir. Cardiologists' heart get hurt whenever you say aspirin and GI bleed, because we really take aspirin close to our hearts. Anybody has got anything to add? We have about 10-15 more minutes of time left. Anybody has got any thoughts or questions regarding this particular case and this particular topic that we are talking?
Good evening, Dr. Anoop. This is Radha.
Yes, Dr. Radha, please go ahead.
Yeah, just to add on from dietitian's perspective about the whole discussion that I listened to, it was very well explained, and really some points I had to really learn and understand from what Dr. Shankar and Dr. Guru said. But whatever may be the medical correction, possibly a dietary correction would go a long way if there is any no medical reason for iron deficiency anemia in this patient. And as Dr. Guru pointed out, yes, consumption of tea does have a role. So that's a dietitian's role, that before giving an intervention plan, we do find out what are these major sources which would contribute to lowered absorption of iron in the body. Taking vitamin C is one such thing, or sometimes what we tell them is not just take vitamin C. What you can do is mix fruits and vegetable salad with lots amount of sprouts, which is also vitamin C. And another point added to the increased tea consumption is increased use of tamarind. See, what generally as a practice in our Indian cooking is, you make palak dal, for example. For the sourness, to have the sourness for the dal, they add tamarind juice, where it kind of chelates with the iron, and the iron is unabsorbable from the green leafy vegetables that are added to the dal. So that is another thing that we need to educate the patient to say that it can be lime juice, it can be raw mango, which can be done during the seasonal availability. So these are small things, and never to take tea along with any meal. Our practice again is immediately after breakfast, we drink a chai. So these are small things which can add value to the whole interdisciplinary treatment for iron deficiency anemia in this patient.
Ma'am, since I have you here, I have a question for you.
Yes.
So this whole green leafy vegetable and iron, is it an urban legend? Is it a myth? Or are we justified torturing our patient, telling them that eat more spinach? What is the real deal?
Not necessary. You need not load the patient with spinach, but make a balance. What they say is eat 5 servings of fruits and vegetables every day. So you find this out and give them 1 serving of fruit. Each of the serving is 100 grams. So if you are able to tell the patient that please eat 1 serving of fruit per day, and this serving has to be specified that it should not be sweet fruits, but should be, the sour fruits. Especially, say, if you take guava has good amount that can contribute to vitamin C. A little raw, so it will contribute additional to the soluble fiber that would contribute. So you take any fresh fruit which is on less sweet, then contributes to vitamin C. And the other 4 servings of fruits, say they're not able to eat all the 4 servings most of the time. Target at least 300 to 400 grams of fruits and vegetables. Just 1 medium size or a small size guava will be 100 grams. So if that is targeted once, then 2 times vegetable, yes. Out of that 2, you can tell them that weekly 3 times you can take it as green leafy vegetable, or add it to the dal. It need not be every day. That's actually a wrong practice.
Thank you so much, ma'am. We do have nursing educators in our attendees as well. I hope they are making notes of whatever we are discussing. Dr. Gauri, you have something to add or question?
Hi, good evening, everyone. I came in late. I'm really sorry for that. I did not know if there was a smoking history in this particular patient. I did not hear it, so I wasn't sure in this.
Yeah, I did not mention it, ma'am, but he does not smoke. He does not smoke, does not drink.
All right.
Otherwise, pretty boring guy.
Well, I think that is everyone's view, but I would definitely, as a GP, I would definitely put some effort into what Dr. Radha said, understanding the patient's diet really in the true sense. I many a times ask patients to really write down and tell me what exactly are you eating, because I have patients who say, no, we eat non-veg, no, we eat leafy vegetables, no, we eat fruits, but when they really put it down in a paper and you realize that actually diet is all over the place, right? So I think that is one point I wanted to bring up, that maybe spending that little more time in, I actually make like a line, where the timelines through the day are written, and when do you eat what and how do you do it. It takes about, say, 7 minutes extra in the consultation, but it takes a long way in understanding the patient a lot more into what's happening with in what's happening with respect to diet. In a young patient with iron deficiency and with a complaint of non-specific weakness, I would definitely want to know how long has he been experiencing this weakness and what prompted him to do this master check in the first place, right? That because that will also tell us a lot about what brought him to the patient in the first place, to the hospital in the first place, or the doctor in the first place. Secondly, I would also, in this particular case, in a young male, I would send him to a gastroenterologist for a upper GI. I usually do not delay a GI referral in a person who has iron deficiency, in a male with iron deficiency. So my prescription usually goes out with saying, and it takes a lot of counseling as well, because no patient wants to really go through an endoscopy. But with men especially, I would want to refer early to a gastro, and I would definitely give this person a deworming, as said by Dr. Guru and Dr. Shekhar. Absolutely, I would deworm. I would give a oral iron, and give a proper dietary advice, and refer early on, to find out if there is something else that we are not seeing, or something else that can be quickly caught. So definitely would want to look into that. I agree with all the other points that have been said and very well explained by the esteemed doctors.
Thank you so much, Dr. Gauri. And as most of you know, that whenever I pick up a topic, I give a couple of minutes of my justification to the topic. So from a cardiologist viewpoint, who is not, I shouldn't say, but we don't pay as much respect to the anemia as what it deserves. A lot of us, and I'm equally guilty of that, if this patient would be a 42 female with no other major issue, then I have done it, and I have seen it being done, where the treatment or the order set includes only and only iron therapy and probably some gynecology history, plus minus referral to gynecology. But other than that, we pretty much stop there, and only in those patients who have recurrent anemia or who have got anemia that do not respond, that triggers further evaluation. The reason why I put on male here is because that gender difference itself should trigger a red flag. And that is one thing that I wanted to highlight, that even if we are not going very actively to evaluate a young or middle-aged female for iron deficiency, it's not the same for the males, where we definitely should go for aggressive intervention. And for that matter, postmenopausal women as well, because there is no reason why they should be losing blood. My question to the audience is there anybody in today's audience who would only do iron therapy to this patient and not do anything else in terms of wait and watch and see how things go? in middle-aged male with iron deficiency anemia is doing iron supplementation alone as the first order of business. Is it sufficient? Is there anybody who would like to take that approach and would defend their approach? And while you think over it, Dr. Shankar, you have something to add?
Good evening. Only thing is, only at the conclusion, I would like to see, in spite of investigating a lot regarding the iron deficiency anemia, still in 5% of the cases, we may not find the reason. So that's why even in the hematological textbooks, they mention lastly idiopathic. And the second one is, see, we think that it is an iron deficiency anemia and we treat it and the patient won't respond. Then in that case, our diagnosis might be wrong. We should, again, we should search for the same. And sometimes hemolytic anemia also may be missed, or anemia of chronic disease or inflammation will masquerade this iron deficiency anemia. These two things. And one more thing, paradoxical thing is, the iron deficiency will be there without anemia. There is one condition. So iron deficiency will be there with the normal hemoglobin. So there is no anemia. So when the patient comes with a restless leg syndrome, periodic limb movements, or sometimes the chronic fatigue, most of the time patients complain. Then when we order for the serum profile, iron profile, we see the CBP, the hemoglobin will be normal, but iron deficiency is seen. Serum iron will be, or serum ferritin may be low. So in that case, so we have to supplement with the iron. This condition one has to keep in mind, that iron deficiency, but without anemia.
Dr. Shankar, one question. Guru sir, I'll get to you. Dr. Shankar, one last question. Santosh asks, when do you check hepcidin level? Do you check hepcidin level at all?
Now, when the patient does not respond to iron therapy, then what is the hindrance? Then we'll go for hepcidin levels. The hepcidin levels are increased, then we'll search for any chronic disease or chronic inflammation in the body. What could be the cause? So sometimes it may be some, I don't know, but it may be hereditary also in some of the patients. There is one condition known as hereditary iron deficiency anemia. So hepcidin levels sometimes in few of the individuals may be elevated. So that where we can find out the cause for this refractory anemia in this case, if the hepcidin levels are high, we think that this is, so there we go for parental iron. I've got one patient, he's an ex-MLA. We are regularly giving erythropoietin and as well as IV parental iron. Because oral iron, any amount, tons of oral iron you give, it tolerates, but there is no increase in iron levels, hemoglobin levels. So then we have resorted to this parental iron therapy along with the erythropoietin. He is responding. Every 6 months, I am giving this parental iron therapy. Thank you.
Thank you, sir. Guru, sir, your comment?
I think it's just an interesting point I want to share with you people, because we don't, somebody had asked me what pica means actually. And I was actually clueless. This was during my MBBS days. And then when we went back and read about it, it came from the Latin word for a magpie bird, which is pica pica. It basically accumulates all food which is, or items which are unfit to be eaten. So that's where the word pica came from. And this pagophagia, which is consumption of ice, is one specific pica symptom for iron deficiency anemia. Other forms of pica can be seen in psychological conditions also, paint and etc., chalk and etc. But consumption of ice is a very specific, like restless leg syndrome, is one specific symptom for iron deficiency anemia. It's a very interesting point I want to share. Second point is that what Dr. Shankar was telling about anemia of chronic disease, the therapy which is mentioning erythropoietin with IV iron is generally for CKD patients. in whom the ferritin levels range between 100 to 500 and transferrin saturations are low, below 20. So that's when we use this kind of intravenous iron and erythropoietin therapy. Other cause of anemia of chronic disease probably doesn't really work, or it's not recommended to use.
Sir, one question that came particularly for you is, what combination of albendazole ivermectin do you use? You said there is a combination tablet.
Yeah, there are two. One is a 6 milligram and 400 milligrams, which is like, I don't want to use the names, the brand names here, but one comes with a combination of 6 and 400, and second one comes with 12 and 400. Generally, for stronger doses, we generally use the 12 and 400 combination. It's a chewable tablet, and it can be had at bedtime. Bedtime, because some people can get little giddiness with the use of albendazole. That's why it is prescribed at bedtime to be used. So generally, I recommend using 12 by 400 combination, and that should be more than enough for eradicating strongylosis and hookworm simultaneously.
Perfect. Thank you so much, sir. May I invite Dr. Somaraju, sir? Sir, you heard us discussing about this pretty common topic, but an uncommon presentation. What is your input on this, and any suggestions for us?
Thank you, Anoop. We are not specialists in this area, but anemia belongs to everybody. All specialists, subspecialists, and generalists, all that. But how you treat it also depends upon the nature of your practice. Many of us, I agree with somebody from general practice mentioned they don't rush for investigation. That I agree, because the type of patients we see in a tertiary care hospital versus the type of patient you see in general practice are different, and I agree with that. Having said that, most of our patients are above 50s and 60s, and one wants to know whether this patient is on aspirin. Actually, many of our patients are also on aspirin, and the first clue to underlying GA malignancy can be unexpected anemia in a patient who is on aspirin. That is one of the ways it comes out. And having said that, and many of these, having investigated and then you found iron deficiency anemia and you have to correct it. Many elderly people, particularly older individuals I'm talking about, they don't respond to oral iron. They don't absorb it properly. Many of them require intravenous iron, and you have to keep that in mind. And intravenous iron can be safely given with some precautions, and either single dose or two doses or 3 doses or whatever it is. And also Dr. Shankar mentioned about anemia in a CKD or a dialysis patient, and they are the ones who are best suited for intravenous iron, because every time they go through dialysis, intravenous iron can be administered at a dose that is essential to them. And I'll leave it at this. Thank you. I also learned a lot of things. And
thank you so much.
Also, amongst the causes, Dr. Shankar mentioned, I hope he mentioned copper deficiency. The commonest cause of copper deficiency appears to be a lot of zinc-loaded multivitamins in our populations. You should be aware of it.
Thank you so much, sir. One question that is added in the chat box is, does the low hemoglobin affect A1C value? This is brought up by Dr. Gauri as well.
Yes, it does.
Yes, absolutely. So, Dr. Gauri, your point is well taken. In patient with anemia, HbA1c can be spuriously low for obvious reasons. So in anemic patient, we cannot rely upon A1c for diagnosis. And also in a patient with established diabetes, A1c cannot be taken as a measure for control.
I'll correct that, Anoop. Actually, it is HbA1c cannot be used as a marker of diabetes for a patient having hemolytic anemia, because the lifespan of the RBC comes down. So the amount of time that the hemoglobin is glycosylated comes down because the rapid turnover. So it's more fallaciously low in patients having hemolytic anemias like thalassemia or B12 deficiency, where there is hemolysis going on. HbA1c cannot be relied upon directly as the marker for the amount of the severity of diabetes.
How about for iron deficiency anemia, sir?
Iron deficiency anemia, the lifespan of the RBC is normal, Anoop.
Okay.
So though it doesn't, so what we're talking about is HB value, HbA1c. The HbA1c depends on the amount of time that the hemoglobin has been glycosylated because of excess glucose in the blood. So by same analogy, any patient having a low RBC lifespan will have a spuriously low HbA1c.
Right, but the way I used to think is that if hemoglobin is 9, your A1C cannot be more than 9, right?
It cannot be more than 9 because obviously the amount of hemoglobin is also less, but the direct proportion is not there. That's what I mean. There was a question asked me in a CME, so I actually went back and read about it. It's not a direct proportion as like we have seen HbA1c, like hemoglobin of 6 and HbA1c of around 10 in a patient, and there are patients in the hospital also. So what I'm trying to tell you is it depends on the amount of time the hemoglobin has been glycosylated by the glucose, which reflects the HbA1c value.
Perfect. Thank you so much, sir. Two things in the chat box. One is the link for the WhatsApp group for the huddle where you can join for offline discussion. And the second, Dr. Vijay has mentioned about the drug, which is a combination of ivermectin and albendazole. So that's the brand name that you can look into and use as required. It is 8:11. If anybody else has got any really burning thought, maybe we can take, otherwise we can close the session. Praneeth, your final comments about today's discussion?
Yeah, so a common thing, but many unknowns for me. And thank you, Dr. Guru and Shankar, for bringing up a lot of discussions. The copper deficiency with the usage of zinc tablets is a learning point for me. Thank you so much, sir, for bringing this up. And with the COVID thing, the zinc supplements are rampantly being used. So probably this is something which we need to look into it. And evaluation of upper GI endoscopy and adding a note of rapid urease test and plus minus duodenal biopsy, provided the patient is not on any blood thinners, is value addition. I think we should discuss with our gastroenterologist to be more cooperative in this regard. And yes, it adds a bit of a cost, but probably equally adds a value in the diagnosis of iron deficiency anemia. The role of the combination of adding not only albendazole but an ivermectin, eliminating few more bugs, and good to know that there is a combination pill which contains both these things, so that makes life easy. And remembering the point to giving it bedtime to improve the patient compliance, and digging deeper, looking into the diet and family history and other evaluation should not be forgotten. So definitely many points that I learned from this very common scenario that we encounter in a day-to-day practice. Thank you, Anoop.
Thank you, Praneeth, and thank you all of you for attending today's session. Thank you, Guru sir and Shankar sir, for your valuable insights. Very, very pertinent. And I think a lot of these, for these patients, we are our first point of contact. So at least we should refer them early before they miss the bus. And by referral, I mean both to the general physician or to the gastroenterologist or to the dietitian. But definitely these specialized care, or I should say consolidation of care, is very important in this kind of subset. So with that, thank you all. I bid you good night, and we'll see you next Wednesday with a new topic. Till that time, if you do have anything that you think we should include in our future huddle discussion, please shoot us an email and we'll be happy to be a part of. Dr. Abhijit, do you have something to add? You raised your hand. Okay, that was probably by mistake. All right, good night, everybody. Thank you so much. We'll see you next Wednesday. I'm closing the session now.